Podemos empezar la grabación. Muchas gracias. Es un gusto saludar a todos ustedes, todos los colegas de la organización, los directores, representantes de los centros colaboradores de nuestra región, investigadores, personal de comunidad científica. Hemos hecho todo un esfuerzo para asegurar que este webinario sea ampliamente conocido y que podamos tener lo máximo de personas participando de este momento tan especial que es el lanzamiento de este número especial relacionado al trabajo, a la cooperación técnica, a colaboración de los centros colaboradores de la OMS en la región de las Américas, que se publican en otro instrumento tan importante que es la Revista Panamericana de Salud Pública. Antes de dar continuidad y empezar nuestro evento con una muy breve introducción, me gustaría simplemente de acordar a todos los participantes que tenemos interpretación simultánea al inglés, al español y al portugués, y simplemente pueden buscar ahí en el panel de control el símbolo, que es un globo, donde pueden elegir los idiomas que quieren escuchar y seguir nuestro webinario. Luego, para un tema también de asegurar más calidad en la transmisión, yo pido muy amablemente a los panelistas y moderadores de la sesión que por favor pongan sus micrófonos mudo, justamente para asegurar que no tengamos ruido y ningún problema de aprovechar las intervenciones de los moderadores y de los panelistas. Por un tema también de logística, los micrófonos y cámaras de los participantes van a estar desactivados y vamos a asegurar que ustedes puedan hacer alguna interacción con los participantes, con los panelistas y moderadores a través del Q&A. Entonces, tenemos una sesión también como un icono ahí en el Zoom que se llama Q&A, que pueden postear sus preguntas, sus comentarios a largo de nuestro evento. No vamos a tener, por una cuestión de tiempo, espacio para abrir los micrófonos y hacer preguntas específicas a los autores o panelistas. Entonces, los moderadores, por favor, van a estar atentos para que las preguntas, los comentarios puestos en el Q&A puedan entonces ser respondidos en esta misma interfaz. Cualquier problema de audio, que no se ve bien, que no se escucha bien, que hay un problema, ojalá no pase con la interpretación, pongan por favor en el chat, así todo el equipo de organización puede rápidamente identificar el problema y tratar de resolverlo, arreglarlo lo pronto posible. Entonces, dado este aspecto logístico de nuestro webinario, más una vez sean muy bienvenidos, esperamos que tengamos una experiencia muy provechosa de conocer más sobre este universo de los centros colaboradores y también de la revista. Simplemente para dar contexto muy rápidamente, la Organización Panamericana de Salud, es una organización que cubre la región de las Américas, es también la oficina regional de la Organización Mundial de Salud para la región de las Américas, y ahí existe esta integración con los centros colaboradores. Tenemos 52 estados miembros, países y territorios, donde ayudamos a promover y a trabajar en el logro de mejor salud, mejor sistemas de salud, control de emergências e desastres y avanzar para salud para todos. Entonces, aquí están nuestros estados miembros, los estados asociados, países que participam deste entorno e países observadores. Então, é um contexto bastante importante para ir aterrizando e ir llegando en la importancia de este número especial que busca la convergencia entre los centros colaboradores y la producción y el compartir información y conocimiento. La agenda de cooperación técnica de la organización, que también va de encuentro y se alinea con el quehacer de los centros colaboradores, se concentran básicamente en estas 6 líneas de trabajo de la organización junto a sus estados miembros y con un elemento también de integración a nivel mundial com a Organização Mundial de Saúde e também com outros aliados estratégicos. Então, estamos falando de um entorno que tem que ver com as enfermidades transmissíveis, determinantes sociais, e environment e meio ambiente. Estamos falando de las enfermidades no transmissíveis, el entorno de salud mental, estamos hablando de toda la salud en el curso de vida, salud de la mujer, de los niños, salud reproductiva, entonces todo o entorno de que sigue el curso de vida de un individuo, sistemas e serviços de saúde, ter serviços mais resilientes, mais preparados, mais listos a responder com tantas necessidades de nossos estados membros e região, estar preparados para emergências e desastres em nossa região e assegurar que tenhamos uma cobertura, uma assistência de qualidade, tanto aos estados membros, também como o entorno. E, mais importante, neste contexto de nosso webinário, o entorno de informação e generação de conhecimento e informação. Neste módulo, aterrizamos também para um outro componente que é importante, o entorno de la organização, em que vai buscar em seus princípios que seja uma organização basada em evidência, basada em informação e conhecimento, que seja uma organização basada em la colaboração efetiva, que seja uma organização basada e que busque enseñanza contínua para que pueda buscar e inovar em si e também junto a los Estados miembros, e uma organização que está basada em alianças e em redes. Então, são palavras muito importantes para o entorno do trabalho que estamos fazendo juntos aqui neste momento. Compartilhar experiências, compartilhar inovação, documentar evidências através de redes, de las alianças, através de los centros colaboradores e deste instrumento tão importante que é a revista. Aterrizando um pouco mais os pilares de gestão do conhecimento, de compartilhar conhecimento, que é o trabalho de nossa unidade, assegurar que tenhamos metodologias, herramientas, plataformas que puedan fortalecer la capacidad, prover mecanismos de compartir mejores prácticas, lecciones aprendidas, generar conocimiento, generar evidencia y un ambiente multilingüe, o sea, que los estados miembros, que los investigadores encuentren las puertas también para promover su conocimiento en su propio idioma y con esto reducir la brecha digital y fortalecer las redes y el panamericanismo. Los centros colaboradores en la región de las Américas suman al día de hoy 178 centros colaboradores distribuidos en 16 países. Acuérdense del slide que hemos enseñado los 52. Entre estos 52, 16 países y territorios tienen en su alcance también hospedar y tener instituciones que sirven como centros colaboradores. Es válido acordar que los centros colaboradores para la región de las Américas son también reconocidos como centros colaboradores de la OMS, por este hecho también de que la organización tiene doble sombrero, por así decir. Estamos con la OEA y también con la OMS. Entonces, tenemos esta licencia de usar en el nombre, la palabra, el título de la organización. Por su vez, la revista congrega mucho del aspecto de red y de descoverabilidad de información. La revista fue lanzada, fundada en el 1922, celebramos 100 años de la revista el año pasado. Es una revista trilingüe que permite la publicación de sus manuscritos en inglés, en español y en portugués. Es una revista revisada por pares, que se accede online, que sigue los estándares internacionales, principalmente del acceso abierto, y no cobra para que autores publiquen y tampoco para que lectores accedan a su información. Entonces, la convergencia de estos dos universos fue lo que logró este entorno tan importante. No quería dejar de hacer esta introducción sin antes reconocer el equipo de trabajo, Sandra Wanger, que todos ustedes seguramente los directores de centros conocen muy bien, a Damián y su equipo de la revista Panamericana, y todo el equipo también del trabajo institucional que han logrado subir todos los manuscritos en nuestro repositorio. Entonces, literalmente, este proyecto fue un entorno que tuvo la participación de todo el equipo de nuestro departamento, de nuestra equipo de unidad técnica de gestión del conocimiento. Con esto, termino esta breve introducción y le solicito, entonces paso la palabra a nuestro director de departamento, Dr. Sebastián García Saizó, director del Departamento de Evidencia e Inteligencia para Acción y Salud, donde se ubican justamente la Unidad de Gestión del Conocimiento, los centros colaboradores y la revista Panamericana. Doctor, muchísimas gracias por estar aquí con nosotros y le paso la palabra para la apertura oficial de nuestro webinario.
Thank you, Eliane. Please allow me to switch to English. I must start by complaining that Eliane didn't have a timer on, and now I have a timer on. I don't think that's equitable. But anyhow, I don't want to repeat. Eliane gave a very broad and complete perspective of why we're here and why this is so relevant for the work that we carry out in the organization, and something that, of course, is not done alone. So it's not just the organization working to fulfill these needs and these goals set by the member states. It's a work that we do with all of you. We do with collaborating centers. We do with all of the institutions that work together with PAHO and WHO to advance in this agenda, and of course, to acknowledge and try to respond to many of the health needs that member states and of course communities, families and individuals have in our region. I want to welcome everyone on behalf of our director, Dr. Jarbas Barbosa, and I want to especially welcome the heads and representatives from our collaborating centers, all of the moderators and panelists that make this possible, and of course the whole team from the Department of Evidence and Intelligence for Action in Health that make this webinar and indeed all of the collaboration possible. As many of you recall, in April 2021, we all gathered together for our PAHO WHO Collaborating Centers regional webinar. This was named Engaging Our Partners to Achieve the SDGs Together. And that's precisely the spirit that we want to convey today. That it's a work that we all do together, in which we all participate, and where we need, of course, to bring it in together and set up also the future work together. That webinar back in 2021 had the main goal of engaging and re-engaging collaborating centers as we discuss how we could all support the organization and the work carried out by PAHO in its effort to achieve the goals of the 2030 Agenda for Sustainable Development. We were really glad to receive back at that webinar several recommendations from the technical, strategical, and logistical perspectives. Two recommendations in particular led us to the production of this special issue of the Pan American Journal of Public Health that today we're launching with all of you, entitled "To Increase the Visibility of Collaborating Centers' Work and to Find Innovative Ways of Providing Technical Cooperation." So during 2022, we took the task very committed to set up what now is translated into this amazing special issue, both as coordinators of the collaborating centers and of the Pan American Journal of Public Health. A call for abstracts was organized, and we received 64 proposals, of which through the whole editorial peer review and screening processes, we're able to select 60 of them for publishing and are now available in our institutional repository. These papers cover several areas, and Eliani was giving some examples from this, from public health, and also showcasing some of the work carried out by collaborating centers, both on the direct one-on-one collaboration, and of course also through the various collaborating centers networks in existence that are key for maintaining and strengthening the role of collaborating centers and the impact of the work that we all together develop. And so we're very pleased to launch today this special issue that celebrates the achievement of our common goals. And during this event, we will learn more about the production of this special issue, the special focus that the papers have, and of course, the work that we all do together. And as Eliani was also saying in her presentation, besides being a milestone for the collaborating centers in our region, we are also particularly proud that this special issue is part also of the celebration of the 100th anniversary of the Pan American Journal of Public Health. The first volume of the journal, published in May 1922, when it was still named as the Boletín Panamericano de Sanidad, or the Sanitary Pan American Bulletin, had in the 3 papers that were published in that first number, one that spoke precisely of the importance of the cooperation in health, entitled La Importancia de la Cooperación Sanitaria entre las Naciones, a paper that 100 years back describes exactly what we are trying to build and what we've accomplished as this very strong group of collaborating centers. Since then, it is a remarkable trajectory of continuous publication at the journal, and this has allowed the journal to maintain its focus on the priorities in public health, and also serving as a scientific vehicle for knowledge generation and, of course, sharing, promoting the use of evidence for decision-making, combating the misinformation, and as an open space for the scientific community to make their discoveries available. I want to thank all of you for being here today with us, celebrating these 2 very important moments, and of course, for being part of this amazing group that we share in terms of the work towards improving health and living conditions in the region of the Americas. So congratulations to you all. Welcome. And I hope we have a very successful webinar and a very interesting session to learn more on the work carried out by collaborating centers. Thank you, Eliani. I give the mic back to you, and I look forward to hearing all of our panelists today.
Thank you very much, Dr. Garcia, for such enthusiasm words. Very important for us, those remarks. Without further ado, and for the sake of the time, Sandra Weinger, please go ahead, as you are going to give us a very brief summary of the special issue. Thank you.
Thank you very much. We're very happy to be here, very excited. This is a dream come true for all of us. So yes, the region of the Americas has benefited from the support of PAHO Collaborating Center since 1950, when the first center was designated in the United States at the School of Medicine, Johns Hopkins University. And since then, as Eliane mentioned, collaborating centers have supported PAHO in many technical areas. Against the background that Dr. Garcia described, once again, we Together with the journal team, we decided to provide collaborating centers in the region an opportunity to make their work visible in a well-recognized peer-reviewed journal, the Pan American Journal of Health, Pan American Journal of Public Health. The call for abstracts was issued. 64 abstracts were received, as Dr. Garcia mentioned. 17 went through peer review and 16 were approved for publication. In the link to the journal site that you will see, we have 15 of those articles. One of them is on its way. It will be finalized shortly. But we also wanted you to know that that we will also be including an editorial in the special issue, and that will be ready at a later date. We thought that it would be nice to include the webinar, mention of the webinar, and some of the results that might come out of this webinar in the editorial. So please look out for that at a later date. So the articles present activities and research results that could contribute to evidence-based health policies, share lessons learned, identify best practices, and helps to increase the overall visibility of the Collaborating Center's work in the region. And that is one of the things that we are doing in many different ways, not just with the journal. So through the 6 panel sessions, we'll learn more specifically how this is done, how their work contributes to the organization. So I will thank you very much again and turn it over to Eliane.
Thank you very much, Sandy. Very, very comprehensive perspective as well. Just for everyone's note, we just shared in the chat the link for the special issue. So we invite everyone to visit and to check the titles of the articles that are freshly published in the journal. It's my pleasure to start the first panel that we are going to learn about the papers related to the non-communicable diseases and risk factors. For that, I'm also very pleased to invite Dr. Claudina Caetano. She's our advisor on mental health here in PAHO headquarters. She will have the task to coordinate this panel. Very kindly, a reminder for the panelists to please take a look to the timer. We are going to start for every one of you. Each one of you have 5 minutes, and for the sake of the event, I appreciate that you follow the timer. Thank you very much, Dr. Caetano. You have the floor.
Thank you so much, Ms. Eliane. It is a great pleasure for me to moderate this the first panel, which has to do with non-communicable diseases and risk factors. We have 3 panelists, and as Ms. Eliane just mentioned, it's so important that you please stick to our time. We want to be able to respect every panelist, give them the opportunity to present. So the first presenter for this panel will be Dr. Arturo Cervantes Trejo. Dr. Cervantes is from the Faculty of Health Science, Universidad Anahuac de Mexico, and he will be talking to us about estimating the economic impact of interpersonal violence in Mexico in 2021. Dr. Cervantes, the mic is yours.
Thank you very much. Are you watching my presentation?
Yes, we are.
Okay, it's a pleasure on behalf of the Harvard Medical School, the program on global surgery and social change, one of the collaborating centers, and Anahuac University to present this study. As they said, it's about estimating the economic impact of interpersonal violence in 2021 and projecting those costs to 2030. Our work basically does the following. We present an estimate of the economic impact of violence in Mexico starting in 2021, which is equivalent to almost 50% of the national GDP. That's about $192 billion. We use data from different sources to calculate the cost associated with different types of violent incidents. And we estimate that by reducing violence in 50%, we could save at least $110 billion in Mexico, which would benefit significantly all Mexicans. The article emphasizes the importance of science-based prevention as the most efficient way to respond to crime and violence and improve citizen security. What we did is we looked at victimization trends from 2000, from the year 2000 to the year 2021. The rates are staggering. Just notice that there's of 126 million Mexicans, more than 20 million have been victims of crime. More than 30 million Mexicans spend on private security an average of $400 approximately. And there has been more than 43,000 homicides last year, giving us an incredible rate. There you see some of the aspects that we looked at in the article. And what we did is, using the trends from 2000 to 2021, we projected how things are going in the blue line, if things get worse in the orange line, and if things get better. And using this, we were able to estimate that this year, for example, Mexico is going to lose more than 224 billion pesos in direct and indirect costs related to violence, and more specifically related to armed violence. The economic cost of violence is staggering. If we don't do anything about it, this is going to continue increasing. And we conclude that these costs are staggering, 15% of GDP. This year, it's going to grow to around 17% of the national GDP. And if we could reduce violence, we could stop spending and throwing away so much money and investing it in public health and in development efforts. Our study recommends investing in evidence-based violence prevention strategy to be able to redirect this money to other government services we need in our country's strategic and science-based prevention. And this will help us improve health, combat poverty and inequality. One of the core problems of this epidemic throughout Mexico and also in the Central American regions are guns. Over 70% of crimes and homicides committed in Mexico are committed with US-made or manufactured weapons. Thus, we have created this network to prevent gun violence in the Americas, because there is a very strong association with the guns produced and imported and into the United States and the crime and violence epidemic that is happening in Mexico. This activity supports the organization's goals and mandates in several ways. We highlight the significant economic impacts of violence, underscoring the need for greater investment in public health strategies to prevent violence and improve citizen security. We emphasize the importance of prevention as the most efficient way to respond to crime and violence. And we underscore the importance of addressing the social determinants of health and promoting health equity. And all of these activities align completely with PAHO's mandate to advocate for health as a fundamental human right and to promote policies and actions that address the social determinants of health and universal healthcare coverage in the Americas. Thank you. That's 5 minutes.
Thank you so much, Dr. Cervantes, and thanks a lot for sticking to the time. Fantastic opportunity to see the value added that you bring to the organization. And I think it's definitely opportunities to look at the returns of investment, what does it mean to invest in this area? Because as you mentioned, rightly mentioned, we know that violence has significant economic impact across multiple domains, including the opportunity of not, the cost of not engaging in basic prevention policies and failing to invest in other social programs that should be prioritized, such as health, education, infrastructure, and social development. So clearly there is opportunity, and I like that you also presented what are the importance of investing in evidence-based. So like we have the tools, and it's important to be able to start to raise awareness of the need for action to reduce violence in the region of the Americas. Definitely, I like that you were able to look at the key priorities, how these contribute to the work that we do in the organization is clearly relevant to PAHO, since without attention to violence, the health and well-being for all at all ages in the region of the America cannot be assured. So preventing and responding to violence is a core to achieve the Sustainable Development Goals in the Americas. So again, thank you so much, Dr. Cervantes.
Thank you very much. And don't forget that we see guns as a public health nuisance for the Americas. And these guns are coming from the United States. And this is a tragedy that is impeding our health, well-being, and development.
We appreciate that. Thank you again. And now we're going to move in the interest of time to make, as I said, we need to make sure we have another presenter in this panel. So the second presenter is Doctora Guillermina Natera from the Instituto Nacional de Psiquiatría Ramón de la Fuente Muñiz, Mexico. My dear friend Guillermina, the mic is yours. And you will be speaking to us on detection of alcohol consumption at the first level of care in Mexico during the COVID-19 pandemic. Over to you. Doctora.
Buenos días. No voy a compartir pantalla, voy a hacer un resumen mejor del artículo. Y muy buenos días a todos los presentes. Agradezco mucho a la OPS haber promovido esta importante reunión y su invitación a participar en este webinar. Aprecio mucho contar con la presencia de todos los colegas de los centros colaboradores e integrantes de la Organización Panamericana de la Salud y en especial mi querida amiga Claudine. Sobre todo tener la oportunidad de comentar con ustedes la participación de este centro colaborador en una investigación internacional que junto con otro centro como es el CAMEISH de Canadá y organismos internacionales pudimos llevar a cabo esta investigación de carácter cuasi experimental en el primer nivel de atención de los centros de salud de la Ciudad de México, orientada a obtener evidencia científica de que es posible la detección temprana y oportuna para la identificación de los riesgos de consumo de alcohol y brindar el consejo breve o referencia al tratamiento. Esta investigación nos dio la oportunidad de elegir el mejor modelo que podría ser aplicado en México. También la Organización Panamericana de la Salud nos promovió y apoyó un webinar el año pasado para presentar el proyecto global que se llevó a cabo simultáneamente en 2 países latinoamericanos como fueron Perú y Colombia. Los centros de salud son centros de atención gratuita por lo general. Asiste la población de más escasos recursos o que no tiene un trabajo fijo y que no tienen acceso a otros servicios de salud como serían los destinados a los trabajadores de empresas privadas, que es la Seguridad Social y los trabajadores del gobierno. Esta investigación se hizo en esos centros y bueno, la metodología utilizada se expresa claramente en el artículo. Participaron 18 centros de salud y 360 profesionales en 4 brazos cuasi experimentales. El estudio muestra una comparación del periodo pre-COVID, el periodo de confinamiento y el post-confinamiento en la detección oportuna del consumo del alcohol. También de la depresión, pero no presentamos en este caso estos datos. Desde septiembre de 2019 hasta junio de 2021 fue que se levantaron los datos. El 63% de la población estudiada obtuvo un puntaje de consumo de riesgo medio y un 3% de riesgo alto. Esto nos habla de que la población que asiste a estos centros de salud es una población que requiere recibir el consejo breve o una canalización oportuna de tratamiento. La aparición de COVID, si bien limitó la afluencia de pacientes a los centros de salud, los que continuaron atendiendo a esta población continuaron aplicando las detecciones y en este caso, como en muchas partes del mundo, se redujo el consumo porque se redujo la disponibilidad, pero no se anuló ese consumo. El estudio nos refleja bebedores de riesgo medio que siguieron detectando, que se obtuvieron el 69% antes de COVID y solo disminuyeron en un 59%, y los bebedores de alto riesgo continuaron en un porcentaje semejante al original, que fue de 3%. En este estudio podemos ver que el riesgo medio fue el que de alguna manera se incrementó cuando analizamos los datos por los 3 periodos pre-COVID, durante el confinamiento y post-confinamiento, obtenemos que el consumo medio, de riesgo medio, fue originalmente de 35.8, pero durante el confinamiento se incrementó a 43.9 y posteriormente bajó. O sea, no obstante la no disponibilidad de alcohol, los consumidores tienen la posibilidad de obtener el alcohol de alguna manera o porque tenían una reserva. Igualmente, el consumo alto en el confinamiento fue el más elevado, que fue de 5%, sobre todo fue más elevado en relación al post-confinamiento, que fue de 4%. El análisis de retorno de la inversión fue muy importante. El 30% de la población si recibiera detección oportuna de alcohol, podría retrasarse 15,000 muertes cada año. Por cada 100 pesos invertidos en el programa que nosotros elaboramos, que se denominó Escala, se ahorrarían 185 pesos en la utilización de la atención médica. En una proyección a 10 años, se encontró que si se evaluara a 1 de cada 2 personas, se reduciría el consumo de alcohol en los grupos de 15 a 34 años y de 69 años o más. Finalmente, los resultados de este proyecto permitieron que una vez más la fundación que nos apoyó económicamente durante los 4 años anteriores nos volviera a dar un importante financiamiento para los 2 años posteriores, en la que continuaremos como centro colaborador de atención primaria, coordinando este nuevo proyecto en esta fase. Es muy importante que este financiamiento nos lo dieron porque una de las partes que reforzó muchísimo fue el que los recursos también pudieran dar respuesta a una de las iniciativas más importantes de la Organización Mundial de la Salud y de la OPS, que es la iniciativa SAFER, que es incluir en el primer nivel de atención la detección oportuna de alcohol, y estaban participando y la participación de este centro colaborador. Lo que es muy importante es que ya tenemos una evidencia científica de este funcionamiento y las autoridades de la Ciudad de México, de la Secretaría de Salud de la Ciudad de México, nos han dado todo el apoyo para seguir continuando con esta investigación que consideramos es muy importante para México, sobre todo porque el alcohol es el problema más serio. Felicidades a la gran revista, muy útil, sobre todo en las Américas, y larga vida. Muchas gracias.
A ti las gracias, definitivamente, mi querida colega y amiga Guillermina, por la oportunidad también de continuar colaborando con la OPS en este aspecto tan importante como es entender cuál es la importancia de la detección del alcohol en el primer nivel, que es posible detectar y orientar en el primer nivel de atención. O sea, este es un mensaje muy clave, muy importante, y precisamente porque sabemos que en general la población de las Américas consume alcohol en un patrón que es peligroso para la salud. Y entonces, cuando se puede orientar, cuando se puede detectar en el primer nivel, creo que esa es una gran ventaja. Estamos hablando de alcohol como un factor de riesgo para más de 200 trastornos de la salud. Así que nos dejas con mucho que pensar, con mucho que seguir trabajando en este tema, y muchísimas gracias por estar con nosotros.
Gracias.
Bien, para terminar este panel, tenemos a bien, y para estar a tiempo, voy a ahora pasarme al inglés. Thank you so much. And now for the third panelist, we have Dr. Catherine Lam. Dr. Lam from the Department of Global Pediatric Medicine, St. Jude's Children's Research Hospital. Dr. Lam, the mic is yours.
Thank you so much. We are delighted to share about our work on partnering to implement the Global Initiative for Childhood Cancer in the Americas, prioritizing system strengthening. I'm presenting on behalf of my co-authors, Liliana Vasquez, Patricia Logetto, Zoe Fuentes Alabi, Alejandra Gonzalez Ruiz, Sarah Benitez Majano, Marta Harkin Pardo, Mauricio Massa, John Spencer, Monica Metzger, and Silvana Luciani. My name is Catherine Lam, and I'm the director of the WHO Collaborating Center for Childhood Cancer, based here at St. Jude Children's Research Hospital, and with our partners at PAHO. Cancer is a leading cause of death in children and adolescents, and unfortunately here in the region, close to 30,000 children will develop cancer each year. And at the current health system's capacity, 10,000 or more will die from this disease. For this reason, because there are dramatic disparities between outcomes in the region and what we know can be achieved at optimal capacity, we have been working hard as WHO Collaborating Center for Childhood Cancer together with PAHO, WHO, regional and global partners to prioritize childhood cancer in the context of system strengthening. In the framework pictured here, we have sought to look with our partners not only at service delivery, but also at the workforce, at information systems, medical products and technologies, finance and governance, and importantly, family support and community engagements. With that in mind, we have been working to apply a tool called C5, Country Collaboration for Childhood Cancer Control, in order to define and implement priority actions at a regional level and at the national level, strengthen ministry programs for childhood cancer while implementing together the Global Initiative for Childhood Cancer. This global initiative for childhood cancer was launched at the United Nations in 2018 with WHO and PAHO. And for more information on how we're applying the cure-all approach here in the Americas, you can visit the QR code here at the bottom. Using C5, we have co-hosted regional and national workshops engaging authorities, clinicians, and diverse stakeholders with the goal to map health systems needs and prioritize strategic activities. We have been able to map institutions, organizations, and roles, as well as national strengths, weaknesses, opportunities, and threats across the health system, altogether clarifying the context as well as the actors, the internal and the external factors that impacts children beyond what's happening within one clinic or one hospital. At the same time, we have worked on C4 and C5 modules, developing collaboratively matrices, examining key areas where we can work together to strengthen the health system, and collaborative portfolios of work that would fit well with the national priorities. Altogether, able to achieve prioritized sets of activities for actions, considering time as well as local values, political will, and resources. The results from the 10 countries have been applied to inform country-specific as well as regional action plans. And we have engaged with the partners to incorporate the findings into national cancer control planning activities, as well as collaborative work at a regional level. We have also identified implementation success factors, including the capacity to engage actors beyond the clinic, the importance of enabling flexibility, and focusing on co-design with stakeholders. This joint implementation of C5 has catalyzed prioritization and accelerated strategic action to improve policies, capacity, and quality of care for children in the Americas, aligning with PAHO's goals and mandates. And we're very keen to continue supporting ministries to integrate childhood cancer interventions as part of system strengthening. It has been a pleasure working with and learning from the many partners across the Americas. And thanks to PAHO's leadership, we're thrilled to continue to implement and see the growth of Cure-All Americas, and together through Cure-All to strive for health for all. Thank you very much.
Thank you. Thank you very much. Clearly, you have articulated so well. And not only that, you also you stuck to the time, and that was fantastic. I think we want to encourage, in the interest of the time, we want to encourage our viewers to please make sure if you have any question for our great panelists, please make sure you put that in the Q&A. It's ready there for you to write your questions. You will agree with me that these three panelists bring a clear added value to the work that we do in PAHO. And thank you again to the three of you, to Dr. Lam, Dr. Cervantes, and Dr. Natera for your presentation. So I pass now the mic to my dear colleague for the panel 2 for Dr. Silvia Cassiani.
For me. Thank you, Dr. Claudina Caetano. Excellent interventions. That's okay. No worries about that. Very, very good comments that tell us that we are in alignment with the centers and what the PAHO is doing and how we are addressing those recommendations. So thank you so very much. Without further ado, to start the panel 2, which is related to health systems and human resources, we are also pleased to invite to take the moderation Dr. Silvia Cassiani, who is the advisor for nursing and allied health personnel development here in PAHO as well. Dr. Cassiani, the floor is yours. Obrigada.
Muito obrigada, Eliane. Um prazer estar com todos vocês nessa importante iniciativa da Organização Pan-Americana da Saúde em aproximar-se dos centros colaboradores, ouvi-los e ainda mais de ter uma revista dedicada ao trabalho dos centros colaboradores. Gostaria de dizer que essa sessão vamos tratar especialmente do tema de recursos humanos em saúde e também de uma importante iniciativa de uma rede de centros colaboradores na enfermagem e na parteria que temos nessa região. Gostaria de convidar nesse momento Carlos Eduardo Batistella, que junto com um grupo de outros autores desenvolveu o tema Comunidades Epistêmicas e os Desafios na Formação de Técnicos em Saúde na Pandemia de Covid-19. Por favor, Carlos, você tem a palavra.
Bom dia, doutora Silvia Cassiani, doutora Janet e doutora Madeleine. É uma satisfação muito grande estar aqui para o lançamento dessa edição especial da Revista Pan-Americana de Saúde dedicada aos centros colaboradores da OMS, OPAS. O artigo que eu vou apresentar foi elaborado em conjunto com as pesquisadoras Ana Beatriz Noronha e Luciana Milagres e discute a atuação de comunidades epistêmicas ligadas à formação de técnicos em saúde por meio da análise das ações do Centro Colaborador para a educação de técnicos em saúde no contexto da pandemia de Covid-19. De acordo com a Rede Internacional de Educação de Técnicos em Saúde, RETS, o trabalho técnico em saúde é considerado como todo aquele realizado pelo conjunto de trabalhadores que exercem atividades técnico-científicas no setor e compreende desde as atividades menos especializadas, realizadas por auxiliares e agentes comunitários de saúde, até as de natureza mais complexa, realizadas por técnicos de nível superior. Embora constituam a maior parte da força de trabalho em saúde em diversos países, pouco se sabe sobre quem são, o que fazem e onde estão esses trabalhadores. Essa invisibilidade contrasta com a crescente relevância de seu papel como alternativa estratégica para as políticas públicas voltadas à redução dos impactos da pandemia nos países, especialmente entre a população mais vulnerável e em regiões remotas e desatendidas. Durante a emergência sanitária, momento em que a cooperação em saúde tornou-se extremamente importante, os desafios para a formação de técnicos ficaram ainda maiores. A multiplicidade de demandas institucionais, pedagógicas e de organização dos serviços de saúde fez com que o trabalho em rede se apresentasse como uma oportunidade de reunir indivíduos e instituições na busca de respostas para problemas comuns, favorecendo a constituição de comunidades epistêmicas. Definida como uma rede de profissionais de diversas disciplinas e formações, com experiência e competência reconhecida em um domínio de conhecimento particular, a comunidade epistêmica reivindica autoridade e legitimidade para contribuir com as políticas dentro deste âmbito ou área temática. Seus integrantes compartilham crenças normativas, princípios e explicações causais, noções de validade do conhecimento no domínio de sua especialidade e um empreendimento político comum. São comunidades de pensamento local, nacional ou transnacional que procuram traduzir suas crenças em um discurso social dominante e uma prática social. Não são estáticas, homogêneas, nem imutáveis. Uma rede de especialistas emerge a partir da articulação de demandas de modo contingente e provisório, na própria subjetivação política. Já nos primeiros meses de pandemia, em um seminário virtual organizado pela Rede Internacional de Educação de Técnicos em Saúde, diversas instituições relataram dificuldades comuns que vinham enfrentando na realização de práticas profissionalizantes e na adaptação ao ensino remoto, sofrimento psíquico de professores, alunos e a necessidade de definir novos perfis e atribuições profissionais para os técnicos da atenção primária à saúde. Diante dessas demandas, a Escola Politécnica de Saúde Joaquim Venâncio, da Fiocruz, como centro colaborador da OPAS-OMS, propôs a realização de um ciclo de oficinas com o objetivo de reunir docentes, pesquisadores e trabalhadores dos sistemas de saúde em um espaço de troca de experiências e de propostas para as diferentes questões que se apresentavam. Apesar das inúmeras diferenças entre os países, a mobilização das redes envolveu o compartilhamento de diagnósticos e uma racionalidade baseada em valores para a ação social, como a defesa intransigente do direito à saúde e do papel estratégico dos técnicos no fortalecimento da atenção primária. Ainda que seja difícil concluir sobre a capacidade das comunidades epistêmicas de influenciar diretamente as políticas nacionais, entendemos que a incorporação do conceito à análise de políticas para a formação de técnicos em saúde pode ser bastante produtiva, fazendo contraponto às abordagens deterministas centradas no Estado e na estrutura econômica, o que permite pensar a participação de atores não governamentais na construção de políticas e oferecer maior complexidade à investigação dos discursos que a hegemonizam. Dessa forma, o Centro Colaborador vem investindo no fortalecimento destas comunidades por meio da promoção de espaços de encontro e diálogo das redes, bem como na investigação do papel das comunidades epistêmicas na circulação de discursos e sentidos que produzem as políticas de currículo na formação dos técnicos em saúde. Obrigado.
Muito obrigada, Carlos. Excelente apresentação que nos traz à vista do déficit de recursos humanos na área da saúde que temos, da invisibilidade, não tanto dos recursos humanos como dos técnicos em saúde. Eu não tenho mais o que agradecer o trabalho que vocês realizam no avanço da formação de técnicos de saúde, não somente no Brasil, mas em toda a América Latina, e para nós é um prazer sempre trabalhar com a Escola Joaquim Venâncio, nosso centro colaborador na formação de técnicos de saúde. Passo agora a palavra à doutora Janete Rigby, e a doutora Janete Rigby vai nos contar sobre o fortalecimento da força de trabalho em saúde no Caribe, descrevendo a experiência em 3 excelentes e talentosos países, como Barbados, Grenada e St. Vincent and Grenadines. Doutora Rigby, doutora Janete Rigby, a sua palavra, por favor.
Thank you. Can everyone see my screen?
Yes, we can
Hello?
see your screen.
Thank you very much. And I'm speaking to you today from Mi'kmaq, the traditional territory of the Mi'kmaq people.
I'm sorry.
And I would just like to...
Dr. Rigby,
yes?
I'm sorry to interrupt you. Would you mind to put as slideshow, please?
Yes, it is on the slideshow. Is that not showing?
No, ma'am, it's not.
Oh dear. Let me just exit and try that again.
Maybe,
Your presentation is showing, it just needs to be put on presentation mode.
Yes, I'm not quite sure what's happening there. Can someone else? Yes, it's not, my controls are not working.
Doutora Rigby, just have your slides again and click in the bottom, in the small cup, and we will see the presentation mode. If you can share again your slides, and we can follow you in the presentation mode.
Sure, I'll just keep talking in the meantime. I'm representing Dr. Gail Tomlin Murphy, the director of our Collaborating Center and lead author of our paper, addressing the move towards universal health in the Caribbean through strengthening the health workforce. In this paper, we actually highlighted the development of the HRH policies and action plans in Barbados, Grenada, and St. Vincent and the Grenadines. These policies and action plans set out strategic actions aimed at strengthening the health workforce within each country. I'd like to acknowledge our co-authors, Dr. Benjamin Portes from PAHO, Washington, and Karen Gladbach from PAHO, Washington, who is now retired. Within the development of the policies and action plans, and I'll ask if you can see that now. I don't think it is sharing. So I apologize for the technical difficulties here. But basically what we did was we used the same policy development process, and we worked in collaboration with Ministries of Health and PAHO. And we conducted a situational analysis which analyzed the current health policy context and included stakeholder discussions on challenges facing the health workforce and strategies to address the workforce challenges and strategies to address them. The intersectoral stakeholder consultations involve meetings with various ministries, such as health, education, and finance, and workshops with stakeholders from government, health facilities, educational institutions, NGOs, and unions. These consultations were a key factor in gathering information and formulating the policies and action plans. Through this process, we identified the key HRH priority areas to be addressed. The policy provided the key strategic areas of action with short, medium, and long-term activities within each priority area. And the 2-year action plan identified activities and sub-activities and provided a monitoring and evaluation framework. The policies and action plans focused on priority areas of leadership and governance, HRH planning capacity, strengthening primary health care, organization of roles, pre- and post-licensure education and training, retention and recruitment, deployment and utilization, intersectoral and external partnerships for sustainability, HRH information systems, and HRH research. And next slide. The cross-sectional analysis of the findings found that HRH challenges and priority areas were consistent across the countries, resulting in similar policy priority actions, which also align with the regional lines of action for strengthening HRH for universal health, which are to 1, strengthen and consolidate governance and leadership on HRH, develop conditions and capacities in HRH to expand access to health and health coverage with equity and quality, and partner with the education sector to respond to the needs of health systems in transformation toward universal access to health and universal health coverage. The consistencies in HRH challenges and priority areas. The consistencies in HRH challenges and priority areas in these countries and across the Caribbean community lend support for sub-regional collaboration on HRH strengthening. The CARICOM, with supporting facilitation by the PAHO sub-regional program for the Caribbean, now has a permanent commission on HRH to advance action on HRH across member countries. Next slide, please.
Doctor, I'm sorry to interrupt you. Would you mind to speak closer to the mic? Because we have background noise and echo from your mic, and it's difficult in the work from the translators.
Oh, I'm sorry about that. Can you hear me better now?
Thank you.
Okay, certainly. So the activity in our paper aligns with and supports the work of PAHO's Department of Health Systems and Services, and particularly the HRH unit, with specific focus on developing human resources for health. The development of HRH policies and action plans that are aligned with national, sub-regional, and regional strategies provide relevant strategic directions aimed at strengthening the health workforce, which is a vital component to a strong, resilient health system. Our center's mandate is to build local and global capacity to support needs-based planning of health systems in HRH. And with a renewed focus on HRH, our center is poised to provide ongoing opportunities to collaborate with PAHO, the CARICOM HRH Caribbean Commission, and member countries as they work to achieve their HRH strengthening objectives. Thank you. And my apologies for the technical.
Muito obrigada, doutora Rigby, e foi muito interessante ouvir sobre o desenvolvimento de planos de saúde, a importância que nestes planos de saúde esteja incluído o componente de recursos humanos para a saúde, também escutar áreas prioritárias que os países devem inverter em recursos humanos, como planejamento, retenção e recrutamento, investigação e educação, e principalmente, ao final, ouvir que desenvolver recursos humanos é instrumental para fortalecer a atenção primária em saúde e fortalecer o acesso e a cobertura universal em saúde. Muito obrigada por seu trabalho junto ao Departamento de Sistemas de Saúde na Organização Pan-Americana de Saúde. Dando continuidade, gostaríamos de convidar a doutora Madeline Nagel. A doutora Madeline vai mostrar a vocês uma interessante rede que temos, uma rede pan-americana de centros colaboradores em enfermagem e parteria, e pode ser muito interessante para outros centros colaboradores que assim desejam formar as suas próprias redes de trabalho. Doutora Madeline, a palavra é sua, muito obrigada.
Good morning, Sylvia. It's a pleasure to be here. I hope you can hear me. Sylvia?
Yes, we can hear you very well.
Excellent. Good morning. Good morning. Happy to be here and to speak about this brief report that discussed the development and the results and advantages of developing the Pan-American Nursing and Midwifery Collaborating Centers Network. So I developed this brief report with Dr. Andrea Baumann and Danielle Denwood, both of whom are based at McMaster University's Collaborating Center. I am based with NYU, New York University's Myers College of Nursing Collaborating Center, which is a collaborating center in geriatric nursing education. The director of that center is Dr. Nancy Van Devanter. This project that Andrea and Danielle and I did was to really summarize the development of the network and to talk about the outcomes that we consider to be valuable so that there's consideration for how other groups may wish to develop a network and what that advantage would be to have a network of collaborating centers. So essentially, the network has allowed us to communicate with colleagues and connect among the collaborating centers and various colleagues in them to communicate and discuss issues, exchange information about funding, exchange information about resources, and to talk about the general ways in which we are implementing our technical assignments and our technical goals to strengthen capacity at PAHO, to build the capacity to meet our universal healthcare needs, but to also do that in relation to our various areas of expertise. So for us at NYU, that is aging. The exchange of information has really helped all of us as representatives of collaborating centers to develop a consensus within our groups, to learn about the trends within our own profession, nursing, and how those trends are supporting our work within the WHO and PAHO collaborating centers. It helps us to communicate on the policies and procedures that come down from PAHO to work on our development of terms of reference, to share information across collaborating centers, and to develop ways in which we advance our learning. One of the most instrumental ways was to develop an annual research, actually a biennial research conference, where all of the schools of nursing and related schools within the PAHO region come together once every 2 years to present research papers about the work within the region and what nursing and collaborative healthcare agencies are doing to help us meet our goals. So that research conference advances our goals of mentorship, which links very closely to our goals of capacity building within nursing and other health resources. It also reinforces our evidence-based approach. So those are some of the results of the centers: exchanging information, providing support to one another, learning about the work of other centers and the ways in which we can collaborate. I was also asked to speak a little bit about what we would advise another group of collaborating centers should they wish to form this kind of network. So this 20-year-old network basically has annual meetings, representatives from each collaborating center, they send 2 representatives, and a website and a repository of our work. So we have created structure. So anyone hoping to develop a network of collaborating centers has to give some thoughts to what kind of structure would be feasible, what kind of structure is the most efficient, and what would be the mission of that network? Why would you even go about this? What do we hope to accomplish? It's helpful, of course, if you are all able to meet in person, because that one-to-one contact builds relationships, facilitates our information sharing, and also allows us to work with others in developing various projects. It's important to choose a model that provides some structure. It took us a while to do that in our incipient years, trying to have a mission that speaks to the meaningfulness of our work. And I think I can see from Sylvia's face that I have used my time. I do want to say it's been most gratifying to be part of the center. Dr. Bauman and Ms. Denwood and I are very pleased that this brief report will be included in the special PAHO issue. And I want to thank you for asking me to participate this morning. It's a pleasure.
Obrigada, Madeline. Thank you, Madeline. E eu convidaria os participantes desse webinar para que conheçam e leiam esse artigo e a experiência dessa rede de centros colaboradores em enfermagem e parteria, porque eu tenho orgulho de ser o responsável técnico por esses centros colaboradores, e o trabalho deles em rede tem tornado o meu trabalho e o trabalho deles em conjunto engrandece a todos nós. E dizer que há também uma rede global de centros colaboradores em enfermagem e parteria, que também é um exemplo muito interessante. Muito obrigada aos 3 panelistas e passo novamente a palavra a Elaine para o segmento. Muito obrigada.
Obrigada, Silvia. Thank you also for the diversity of languages. That is one of the goals for the organization, to be able to communicate and to strengthen the multilingualism. So thank you very much for moderating this very important panel also in Portuguese. Muito obrigada novamente. Now let's begin panel 3. No rest for us. It's very intense, but very interesting. Thank you very much for the panelists who have attended so far. We understand that many of you already have other commitments. So before you leave the webinar, thank you very much, and thank you for the patience for the next ones who are still have the work. My special recognition to all PAHO, the collaborating centers located in Cuba, because we just heard that all of you are joined together from our PAHO country office, who opened the space for you to enjoy and to join us together. So thank you again, and our recognition also to our country office for doing this for us today. I'd like to invite now Mr. Olger Gonzalez, who is the Human Rights Advisor also here in PAHO, to lead our panel 3, which is regarding the pandemic preparedness. Go ahead, Mr. Gonzalez. You have the floor to moderate the section.
Bom dia, Eliane. Muito obrigado. I hope you hear me well. It is my pleasure to introduce this morning Mr. Kashish Aneja from the O'Neill Institute for National and Global Health Law of Georgetown University in the USA. They prepared a special report on COVID-19 in the Americas, the role of collaborating centers in understanding lessons and best practices in pandemic preparedness and response. Mr. Aneja, you have the floor.
Thanks, Olga. I'll just share my screen. I hope my screen is visible, right?
Yes.
Perfect. Thank you so much. A very warm good morning, everyone. I'm Kashish Aneja, public health lawyer with the Center for Transformation Health Law at the O'Neill Institute for National and Global Health Law, Georgetown University. Today, I'll be presenting a paper titled COVID-19 in the Americas, the role of collaborating centers in understanding lessons and best practices in pandemic preparedness and response. The COVID-19 pandemic has exposed serious gaps in the international and multilateral systems that we relied on for decades. Yeah.
Can I just ask you to speak a little bit slower?
Okay, sure, sure.
Allow our interpreters to not miss anything very important that you are going to say. Thank you very much.
Of course, thank you. Sure, of course. The COVID-19 pandemic has exposed serious gaps in the international and multilateral systems that we relied on for decades to coordinate global responses to crisis. In many ways, the exposure of these gaps has been troubling, wake-up call that our current frameworks, when tested, proved inadequate. This wake-up call, while it must lead to meaningful change at the international level, it should not overshadow the important work that has happened at the regional level. This paper is based on the work done by the O'Neill Institute in its capacity as a WHO collaborating center, and it argues that regional bodies can and should play critical roles in supporting outbreak preparedness and response. This paper identifies gaps in current response and preparedness mechanisms and examines both the solutions provided by PAHO during the pandemic and the important role for the organization in building sustainable and resilient global systems in the future. The O'Neill Institute has a long history of concretely supporting PAHO's work prior to COVID-19. The Center for Transformation Health Law has been heavily involved in supporting the World Health Assembly in the creation of an international legal instrument for pandemic outbreaks. The O'Neill Institute, along with the Foundation for National Institute of Health, convened 30 of the world's leading authorities on global health law, financing, biomedical science, implementation, and emergency response, along with leaders from prominent international organizations. The global convenings were followed by regional consultations, which focused on the unique challenges faced by the countries in the region. These high-level expert consultations generated in-depth discussions on weaknesses and the persisting gaps in global pandemic preparedness and what a new international agreement might include to address them. So our paper identifies 3 gaps in the current response and preparedness mechanisms. The first is the gap in technical capacity at the country level. There have been, the high-level experts identified a lack of technical capacity at the national level as a serious impediment to the effective implementation of policies. Testing capacity is another area where PAHO played a key role and recognized a need to be involved moving forward. In addition to technical, medical, and health system capacity, the regional consultations highlighted a serious gap in communication capacities, both within PAHO and in national governments. The second gap has been in information technology infrastructure. Discussions about a possible international pandemic instrument have included conversations about the role of data sharing and surveillance. The consultations highlighted a lack of information technology and digital capabilities as a fundamental challenge that impeded data sharing and surveillance during the COVID-19 pandemic. Finally, there are gaps in coordination which have been identified. These challenges included those faced in facilitating coordination between countries and the WHO health offices in Geneva, to those identified by the PAHO officials in coordinating with other WHO regional offices and those between PAHO and other multilateral organizations. The paper also deals with the roles of PAHO in addressing these gaps. While there are, of course, a number of roles, important roles that PAHO has played throughout the COVID-19 pandemic, yet our paper discusses broadly 2 areas in which the O'Neill Institute has seen the most innovative and widespread contributions. The first include standard setting, which saw PAHO's direct influence on developing and changing national level policies, promoting evidence-based best practices, and providing direct technical support to governments. There have been regional efforts to increase vaccine access, which saw the Latin American, Caribbean region and PAHO working in close partnership with the Inter-American Development Bank, as well as COVAX as part of a broad strategy towards vaccine access. The paper discusses these 2 areas with examples of fruitful regional collaboration and solutions to multilateral problems. These areas show that regional institutions are irreplaceable creators, organizations, individuals living and working in the realities on the ground, international organizations dictating priorities and policies. Collaborating centers such as the O'Neill Institute can assist in fulfilling essential surveillance and evaluation functions. Not only does the Institute have ample access to academic resources and expertise in law and policy surveillance, its experience is also complemented by involvement with other international bodies. Just last year, the Institute conducted the first comprehensive analysis of vaccine development agreements entered into by CEPI. These exercises are just small examples of the important work being done at collaborating centers and highlight the role of collaborating centers at critical resources in support of PAHO. By harnessing the collaborating center expertise and resources, and working together to highlight both successes and outstanding challenges at PAHO, we hope to move progressively towards the improvement and protection of health of all those living in the American regions. Thank you for having me today.
Thank you very much, Kashish, for your exposition. The fact is that we have critical gaps in local, national, regional, and international public health preparedness and response mechanisms, which are needed to ensure coherence and cooperation between international and regional mechanisms, right? And that continues to hinder both global and domestic responses to the spread, in this case of COVID virus, but we also gonna face more in the future. So just to take one example of the gaps that you mentioned, there was a serious gap in communications capacity, both within PAHO and national governments. So governments in the region have been faced with a difficult balancing act between communicating uncertainty and sharing clear, reliable, transparent information to curb the spread of the virus. So that created disinformation. This, together with the lack of IT and digital capabilities as fundamental challenges, lead us to think on human rights again. Yes, we're talking about right to health, personal integrity of people, but access to information in times of uncertainty is related with credibility, accountability, transparency of governments, and ultimately their legitimacy in democratic societies. So one of the things that you in your special report addressed was that PAHO worked to connect governments with organizations that could promote a holistic and intersectional approach in handling the pandemic. In times of emergency, states' obligations under international law of human rights and humanitarian law are not suspended, but rather persist. And this is particularly relevant when talking about persons and groups in situations or conditions of vulnerability who should be protected under. So we can think on all the efforts that we try to do within the countries and the organizations, efforts by the Inter-American Commission in addressing indigenous people's needs, migrants, children and women who faced increased domestic violence, extreme poverty in human settlements, when overcrowding simply impeded the implementation of certain preventive measures. So human security is more than a valid concern. We cannot agree, therefore, more with you that collaborating centers like the O'Neill Institute can and should continue to highlight and support PAHO's work. And we must continue to consider the benefits of developing an international instrument on pandemic preparedness to address weaknesses and persisting gaps in global pandemic preparedness. With that said, I appreciate very much for your attention, and thank you again, Kashish. Eliane, passo a palabra. Thank you.
Muito obrigada. Thank you very much. And it's also important, interesting to see how the papers and how the work by the collaborative centers can be strengthened from this kind of dialogues. On the panel 5, we are going to talk about digital health and infodemics. And we are going to learn a very interesting project to fight misinformation. So there's a lot of opportunities for the collaborative work with the collaborative centers. We are running a little bit late on this event, so let me introduce our next panelists. We are not gonna go straight to the next panel for the manuscripts, but now we're gonna have the opportunity to learn a little bit more about the Pan American Journal of Public Health and its perspective of publishing this special issue. I give the floor to Dr. Damian Vasquez, who is the managing editor for the Pan American Journal of Public Health here in the Pan American Health Organization. The floor is yours, Damian.
Muchas gracias, Eliane. Buenos días a todos. Entiendo que están viendo mi pantalla con la diapositiva de apertura. Y esta presentación es un paréntesis entre los temas que estamos conversando, que son el verdadero interés de este webinar. Y como todos los paréntesis, va a ser muy breve. Pero nos parece importante compartir desde la perspectiva de la revista un par de reflexiones. Como ya se dijo, la revista ha cumplido en el año pasado 100 años de existencia, y eso la convierte en una de las revistas de salud pública más antiguas del continente. Y al ser un proyecto transversal de la organización, cuyos resultados se vuelcan a todos los países, la hacen muy parecida a los centros colaboradores, que son otro proyecto transversal y cuyos resultados son útiles para muchos países. A veces surge la pregunta en un taller de redacción científica, ¿para qué publicar? Y la respuesta simple es porque lo que no está publicado no existe. Sabemos que en el 1500 se sabía aproximadamente esto sobre la gestación humana, y lo sabemos porque Leonardo no solo investigó ese tema, sino que además lo escribió y lo dejó dibujado, como se ve en ese cuaderno a la derecha. Y lo que saben los cirujanos de anatomía hoy en día, en buena medida se edificó sobre lo que los primeros anatomistas publicaron en libros, como el que se ve a la izquierda. Si nos vamos 500 años hacia el presente, llegamos a las revistas científicas y podríamos decir que el papel de una revista científica es transformar lo que se ve a la izquierda en lo que se ve a la derecha. Las diferencias son evidentes y son bien visibles, sin embargo, yo creo que lo que más se ve no es lo más importante. Es claro que un manuscrito es un documento que no ha sido revisado ni editado y que un artículo científico sí ha pasado por esos pasos que han aumentado su calidad. Sin embargo, eso no es lo más importante. Lo más importante, creo yo, es que un manuscrito es simplemente un documento que ha sido compartido entre un grupo de autores y una revista y nadie más sabe de esos resultados de la investigación. En cambio, un artículo publicado es una evidencia científica que está disponible en forma amplia para la comunidad académica, los profesionales de la salud, tomadores de decisiones e incluso para la población general. Y aquí entonces es cuando esa evidencia científica, si se lleva a la acción, toma vuelo y se puede generar un círculo virtuoso, porque los investigadores pueden usar esa información de un artículo dado para edificar nueva información y publicar otros artículos. Los profesionales de la salud pueden cambiar su conducta práctica en el consultorio en cuanto a diagnóstico o terapéutica con base en algo nuevo. Los tomadores de decisiones también pueden informar sus políticas de salud o normativas y emitir leyes o regulaciones que hagan a la mejora de la salud pública. Y por último, la población general también, generalmente a través de los medios de comunicación, pueden llegar a nuevas investigaciones y cambiar su modo de vida hacia estilos más saludables. Entonces, esta es en realidad la verdadera importancia de la publicación científica y lo que en última instancia nos interesa en la revista. De manera que solo me resta invitarlos a visitar el sitio dedicado al número especial. Si van a la dirección de la revista, van a ver en la parte media del sitio web un sector dedicado a los números especiales y ahí van a encontrar todos los títulos que son los enlaces a los artículos concretos con los cuales van a poder acceder al texto completo y descargar el artículo. Como ven, los temas son variados, eso es algo interesante de este número especial, no es un número dedicado a un solo tema, sino a muchos temas. Y otra particularidad es que muchos de los artículos no se enfocan en un solo país, sino que son producto de investigaciones que se han llevado a cabo en muchos países, de manera que eso le da un interés regional. Por último, quiero agradecer a muchas personas. A veces decimos que la publicación es un esfuerzo en conjunto, es un trabajo en equipo. Y se me ocurrió hacer una cuenta rápida de cuántas personas tuvieron un manuscrito dado cualquiera directamente en sus computadoras. Si decimos que hubo 5 autores y lo han revisado 3 pares y lo han manejado 2 editores, un tipógrafo, un traductor y otros profesionales que han intervenido en esa sucesión de acciones, en un manuscrito cualquiera pueden haber intervenido 25 personas directamente, lo cual transforma a estos 15 artículos que tenemos aquí en un conjunto de 250 o 300 personas que han intervenido en esta publicación. De manera que yo quiero agradecerles a todos ustedes, a todos los que han intervenido en esta cadena de acciones, en particular a los autores, a quienes me ha dado gusto conocer personalmente y ponerles la cara a los nombres que venimos viendo hace varios meses, lo mismo que a todas las personas que nos han ayudado desde el comité editorial y a todos los centros colaboradores cuyos manuscritos no hemos podido publicar, pero que también nos han enviado en su momento sus resúmenes y, por cierto, valoramos mucho la cooperación que nos brindan. Así que a todos, muchas gracias y te devuelvo, Eliane, la moderación.
Muchas gracias, Damián. Excelente exposición y nuevamente la invitación a todos que puedan leer, conocer y someter sus manuscritos que se van a volver en papers en nuestra revista Panamericana de Salud Pública. Como ya hemos hablado, estamos bastante retrasados en el tiempo, así que me gustaría mucho de invitar nuestra próxima moderadora, la doctora Patricia Morsch, que es nuestra asesora de health aging, the advisor on health aging here in the Pan American Health Organization as well, who will moderate the panel 4, which is related to health throughout the life course and occupational health. Dr. Marsh, the floor is yours. Once again, thank you very much for being here with us.
Obrigada, Eliane. It is a great pleasure to moderate this panel, and I appreciate the opportunity to be here with you all today. So before I pass the floor to our first speaker, I would like to remember that each presenter will have 5 minutes to deliver their presentation. Now I would like to introduce our first speaker, Dr. Jerry Spiegel from the EU School of Population and Public Health from University of British Columbia, Canada. Dr. Spiegel, the floor is yours.
Thank you very much. I should be loading right now.
Yes, we can see your presentation, just have to be
Yes,
added
okay.
in the presenting
yes.
mode.
Okay, no, thank you very much.
It's perfect.
I'm actually speaking to you today from Vancouver, Canada, which is on the traditional, ancestral, and ceded territory of the Musqueam people. My name is Jerry Spiegel. I'm a professor in the University of British Columbia and co-director with Dr. Annalie Yassi of the Global Health Research Program. And although we've enjoyed very much our collaborations with collaborating centers across the Americas, I'll be speaking today about a project we undertook with a collaborating center partners in South Africa at the National Institute of Occupational Health around the theme of protecting healthcare workers during a pandemic. What can WHO Collaborating Center Research Partnership contribute? And this was a partnership that was developed over 15 years ago, interestingly, at a meeting, coming together at a meeting of WHO collaborating centers. So half of our team of authors is from South Africa and half is from Canada. What we tried to undertake in this research that was funded from the International Development Research Center in Canada and the Canadian Institutes of Health Research was a response to the crisis posed by the emergence of the COVID pandemic. And we were called on to say what insights could be added to the challenge of what works to protect healthcare workers during a pandemic, in what context, using what mechanism to achieve what outcome, to really look at what the best practices would be and how we could develop that, share that, and build on the strengths of collaborating centers to develop that further, but sensitive very much to the context, which is one of the shortcomings to enable a good appreciation of what best practices really can mean in practice. To do this, we undertook a realist synthesis of projects. A realist synthesis is a method increasingly popular in implementation science that focuses particular attention on the context. That means at different levels, from the macro, global, national level, to the meso institutional level, to the local micro level of the individual worker. But in this case, we weren't only looking at the realist appreciation of interventions, but of the process of research collaboration. So we were including consideration of researcher positionality. Also, especially looking at the mechanism, which in our case also looked at the service relationships that each collaborating center had, in addition to being researchers, being engaged in supporting best practices and providing service. And finally, to be looking at the outcomes that could be achieved through interventions. And in looking at this, we were drawing on an area of knowledge known as partnership synergy theory, which really looks at the process of partnerships, which, as you know, has been recognized itself as an important issue, partnerships as a sustainable development goal. So within this, we had a particular focus on an assessment of what the role of a WHO collaborating center partnership was in each study and overall. So we actually drew on 7 projects that we conducted in this research program, each of which has been published and
fueron analizados. Entonces, los detalles de estos
Esses detalhes desses estudos estão disponíveis porque já foram publicados.
On to analyze a very early survey that was taken among 161 countries of close to 5,000 healthcare workers to be looking at not only what the results were of meeting the challenge of COVID, but looking at what the effects that economic disparities could be producing, both between high income countries versus low and middle income countries, but also where there was income disparity within countries and economic disparity. Having a comparative north-south perspective gave us a particular strength in looking at these questions. And we indeed saw that there were a greater challenges faced where there was more disparity, which we'll share with you in a minute. We looked at workplace assessment, drawing on the strengths, particularly of our colleagues in South Africa, in providing service to workplaces, healthcare workplaces around the country, and drawing on collaborative work we had done using the WHO ILO WorkSafe tool to promote health and safety workplaces in the healthcare work setting. So we were looking here, for example, at what would be the effects of policy and compliance with good practices, which is what we saw that in fact, in those settings that had policies and good practices, they were getting better results in terms of dealing with the challenge of COVID. We had 4 workplace studies that were looking at comparative perspectives through our collaboration, cohort studies in both South Africa and in Canada, where we would be looking at the effects of control measures taken in vaccination. And then in the Canadian context, a nested case control study where we look deeper at effects of exposure factors and control measures, whereas in the South African context, had the opportunity to follow up some previous collaborative work together to conduct a mental health study that in particular would look at the effect of support and training to workers facing this emergent challenge. And finally, building on what was probably the strongest history of our collaboration between collaborating centers, looking at how strengthened information systems could contribute to meeting a challenge. And in this case, we were really looking at the readiness and feasibility of strengthening workplace systems facing this challenge that was building on a new system that's actually widely used now in South Africa that was the result of an information technology transfer that we developed starting over 15 years ago. So what were the conclusions and results? As I mentioned, lower resource countries with higher economic disparity were indeed perceiving greater occupational health risk and less acceptable mitigation measures to provide protection at the onset, which is an important issue for preparedness, because this won't be the last pandemic challenge we'll be facing, unfortunately. We looked at rigorously adopting occupational health measures. In cases where we saw these being adopted, these indeed afford greater protection. And when it came to the mental health, which is a huge burden in this context, we saw some evidence of training and preventive initiatives contributing to reducing workplace stress. We saw the value being placed on information systems, although this work is mostly ongoing now, but also that we could use the information systems to identify healthcare workers most at risk and then intensify the protective actions being taken. So the CMO, the context mechanism outcome analysis, showed that in working through a WHO collaborating center partnership, this not only enabled knowledge sharing, but from the different perspectives, particularly from the global north and the global south, this could provide greater insights into what works, what's needed, what's feasible. to provide worker protection. Now, what the implications of this for PAHO and beyond is when we meet a challenge like the pandemic, we need particular focus on protecting healthcare workers, as we've seen, and we were able to, through this collaboration, see the value of actually pointing to specific measures that could be taken for this protection. But beyond that, the strengths of the WHO and PAHO Collaborating Center networks create a tremendous basis for generating further knowledge and doing this in a bi-directional learning way across global north, global south, but just across the whole networks. This draws on not only the strengths of collaborating centers among themselves, but each collaborating center in our case had rich partnerships with local decision makers, local government health authorities, and in this case, strong partnerships with practitioners. So this really would intensify the mutual learning and ultimately the sharing that could reinforce work across the PAHO network, particularly for healthcare worker protection. Thank you. Gracias. Obrigado.
Thank you very much, Dr. Spiegel. Very important and relevant topic to present, especially in the current scenario that we have now, still battling COVID-19, but of course, to better prepare for other health emergencies that might arise. We know that sharing best practices, information, and developing research are key aspects for informed decisions. So partnerships, such as with the collaborating centers, can be great assets to address different areas as presented by the different projects that you analyzed, and especially for countries with more disparities, more difficulties, and the countries that will have probably more negative effects in these emergencies. So thank you very much. I'll immediately pass the floor for the next speaker because of the time. So the next presenter is Dr. Fernando Díaz Barriga de la Facultad de Medicina de la Universidad Autónoma de San Luis Potosí, México. And Dr. Díaz Barriga, adelante, por favor. Acuerdo del tiempo de 5 minutos para la presentación.
Sí me ven, pero no puedo hacerla de toda la presentación.
¿No puedes poner en modo presentación?
No. Pero bueno, voy a ir rápido. Nosotros trabajamos sitios contaminados en América Latina. Y en los sitios contaminados, la salud ambiental infantil tiene que ser protegida. La Organización Panamericana de la Salud y la Organización Mundial de la Salud han venido trabajando fuertemente en estas áreas y varios centros colaboradores, no nada más el nuestro, hay centros colaboradores en Uruguay, aquí mismo en México, en Estados Unidos, Canadá, en fin, estamos colaborando con estas instituciones. ¿A qué le llamamos sitios contaminados actualmente? Los sitios contaminados tienen 4 amenazas muy graves. La quimicalización, el mundo está lleno de químicos, más de 300,000 de uso común. La contaminación que mata más que la pandemia, por supuesto tenemos la COVID-19 ahorita, y finalmente el cambio climático. Estas 4 amenazas que afectan a la salud infantil convergen en los sitios contaminados. En estos sitios, las amenazas químicas, físicas y biológicas se sumen a las condiciones de salud y a las condiciones sociales. Todo esto ya lo saben todos ustedes. El problema es, ¿qué hacemos? ¿Qué hacemos más allá de los diagnósticos? ¿Qué hacemos más allá de la información basada en evidencia? Entonces, creamos una estrategia que se llama escenarios humanitarios, donde planteamos la construcción de salud a partir de la eliminación de las amenazas. ¿Sí? La idea es eliminar las amenazas químicas, físicas, biológicas, ecológicas y sociales, basados en el derecho a la salud y teniendo como foco a los escenarios humanitarios. No puedo pasar la siguiente. Eso, gracias. Entonces, esta unidad RISC de riesgos infantiles en sitios contaminados tiene 5 elementos. La formación de talento, tenemos cursos inclusive con la OPS, tenemos programas de divulgación, de abogacía basada en los derechos humanos y de vigilancia. Y finalmente una estrategia que hemos denominado P6, si me da la siguiente, por favor. Esta P6 incluye 6 fases, la de planeación, participación, priorización, prevención, promoción y protección. La idea es crear capas preventivas en las comunidades basadas en los derechos humanos, exactamente como el uso del cubrebocas para la COVID. ¿Cuáles son los elementos que podemos trabajar a nivel local con la comunidad para proteger la salud de los niños? En el artículo van ejemplos en sitios contaminados por mercurio, en minería artesanal y en barrios urbanos marginados. Pero estos 6 elementos, si me da la siguiente, están de acuerdo con el enfoque P5 de la Agenda 2030. Planeación, participación, priorización, prevención, promoción y protección. Todos estos elementos tienen ya estructuras para trabajar a nivel de comunidad. La siguiente, por favor. Esto, entonces, podemos utilizarlos para cuando convergen los riesgos planetarios a nivel comunitario, y actualmente ya estamos previendo con la Organización Panamericana de la Salud y con la Organización de Estados Americanos, trabajar en esta estrategia en 10 países y en 100 escenarios humanitarios. Queremos formar recursos humanos en todas las Américas para que los niños finalmente puedan decir, tenemos futuro. Yo agradezco a la OPS esta oportunidad. Es muy importante que los centros colaboradores entiendan que los retos actuales no son los retos de hace 100 años cuando empezó la revista. Tenemos que estar juntos a favor de la salud pública. Muchísimas gracias.
Muchas gracias a usted, doctor. Y the role of the environment for health is already very clear, an important area of work for PAHO. And the work presented has the focus on children, but I would like to highlight that it's very important to consider a life course perspective. That is another area of work currently in PAHO. So the contaminations and experience in these environments can impact health trajectories. So this study impacts directly children, but on a broader perspective can impact their development and so favor better health in other ages as well. As Dr. Diaz-Barriga said, engaging, having a better future for all. So thank you very much. And to continue the session, I introduce our next speaker, Dr. Semi Almashad, from the Occupational Health Program of the University of Maryland, Baltimore, from the United States. Dr. Almashad, the microphone is yours.
There we go. Sorry about that. Can you all hear me and see my?
We can hear you, but we cannot see your screen. Now, yes.
Okay, great. Good morning, everybody. My name is Sami Almashad. I'm an occupational medicine physician here at the University of Maryland in Baltimore in the United States. And together with my colleagues here in the US and Dr. Muller Ramirez in Chile, we've published an article in this month's issue on carcinogenic drug exposure among health sector workers. So this is exposure among health sector workers to chemotherapy drugs in the workplace and the need for exposure assessment and surveillance. So what is the problem? The problem is that the number of cancers and therefore the amount of anti-neoplastic drug use, which is chemotherapy drug use, is going to be increasing a lot in low and middle income countries over the next 2 decades. And some of these drugs used for chemotherapy can cause cancer in people who are exposed to them. And this includes health sector workers. And these can be workers producing the drugs, workers administering the drugs, workers cleaning up after the drugs are administered. So the objectives of our report were fourfold. One is to review the existing research and prevention efforts, much of which has been led by PAHO and its collaborating centers, occupational health collaborating centers, aimed at reducing occupational cancer in the Americas. We wanted to discuss how very robust exposure assessment and outreach work by PAHO and its CCs can form the basis of exposure mitigation efforts among health sector workers. We also present original exposure assessment data that were generated by our first author, Dr. Muller Ramirez in Chile, in a major pharmaceutical manufacturing facility in Chile, and how successful exposure assessment can be done relatively inexpensively in especially limited resource settings. And those settings can also engage in ongoing periodic environmental surveillance to make sure that they identify contamination and that they identify that the strategies they're using are effective at reducing the contamination. Our conclusions were that there already exists extensive data, much of which has been generated by our own center here at the University of Maryland, Baltimore over the years in collaboration with other PAHO collaborating centers in Latin America, that shows that these exposure assessment strategies are feasible and that the strategies to mitigate the exposures are also very feasible to reduce the risk of occupational cancer in health sector workers. Some of these strategies to assess exposure include wipe sampling. So it can be as simple as taking samples from the surfaces in hospitals to see how much chemotherapy drug residue is on those surfaces, and then running them through relatively inexpensive detectors to identify which drugs are contaminating those surfaces. And this is a necessary first step to then implement the hierarchy of controls that we all know about. Obviously, engineering controls, that should be our aspiration everywhere, including in limited resource settings, to get engineering controls in place, such as biosafety cabinets, things called closed system transfer devices that prevent exit of the drug from the device itself that uses to administer it. Of course, not every hospital, not every healthcare facility in our region can access those engineering controls, unfortunately. So in the meantime, we do identify administrative and work practice controls, and many of these have been identified in PAHO's 2013 safe handling guidance for hazardous drug exposure. And finally, training workers in PPE, training workers in these work practice controls. And the most important part after this initial assessment is to keep measuring exposure after you implement these strategies. And we discussed the need for that in our paper. And finally, this, just to put it into context of PAHO's broader work on this, the risk of health sector worker exposure to chemotherapy drugs in the workplace, it is a prevalent problem in the Americas, and it must continue to be included in PAHO WHO's broader efforts at reducing non-communicable diseases in the Americas, including occupational cancer. And PAHO and its collaborating centers, including us, should continue to play a leading role in outreach efforts to make sure workers are aware of the risks of cancer-causing drugs in the workplace, that institutional officials are aware, and importantly, national officials are aware of this problem and how surprisingly straightforward it can be to make sure you are aware of the problem and you know how to mitigate the problem, including in limited resource settings. And hopefully these efforts will then provide the platform for national policy recommendations to make sure that certain best practices identified by PAHO are implemented in certain countries. And Brazil, Mexico, Chile, these countries all already have national mandates to implement certain safe handling practices for hazardous drugs, including chemotherapy drugs. So this is feasible on a national level, it's feasible on an institutional level, and it can be done very readily in limited resource settings. Thank you.
No, thank you, Dr. Amashaj. We appreciate your presentation. And we can relate this presentation with the previous one, again, concerning the exposure and the impact of the environment for health. Of course, this one with a targeted audience on health professionals. So this is a very important topic, especially regarding the cancer, because it was one of the leading causes of death and morbidity in the region. So it's very important to work in all types of cancer, including occupational cancer. So the recommendations provided are very practical and can support further work of PAHO with the countries. So thank you very much.
Thank you.
To finalize panel 4, I pass the floor to Dr. Nancy van der Vanter from the Rory Mayers College of Nursing of the New York University, United States. Dr. Nancy, the floor is yours.
Okay, thank you very much. And hello to everyone. I'm sure this has been a long morning, so I will get right down to talking about our paper. The title of our paper, I guess I don't have that slide. How do I get to that slide? Okay. Is Healthy Aging and Care of the Older Adult with Chronic Disease. This is a qualitative needs assessment that we conducted in Eastern and Southern Caribbean islands. The authors on the paper are myself. I am currently the Deputy Director of our WHO Collaborating Center. Dr. Madeline Nagel, who is also on this panel, is actually the original director. She's the founding director of this particular WHOCC. Other authors include Nasreen Nizia. She is a senior nursing student who is very interested in the kind of work that the WHOCC does. Dr. Avian Bamadou is a physician, and she is, I believe, certified in the PAHO ICOPE model. And at the time when we were working on this, she was a physician associated with the Organization of Eastern Caribbean States. Dr. Eileen Sullivan Marks is the director and the dean of our school. And I'm the one who's delivering this morning, so I have to move on to the next slide. Great. Okay, the objectives for this study were to identify health priorities and strategies to strengthen health systems-based integrated care for Caribbean older persons. This is consistent with the WHO goal of building interprofessional workforce capacity, and also consistent with the PAHO WHO commitment to this decade of healthy aging. Our center is, in fact, a nursing center, so we are a part of that organization, but our primary content area is geriatrics. So this qualitative needs assessment is informed by the consolidated framework of implementation science, which I believe one of the former presenters also talked about. Implementation science seems to be a very valuable tool for beginning to change things. This was conducted with islands in the Organization of the Eastern Caribbean States, OECS, and we also chose to conduct it with two large, more urban-like southern islands to be able to get a really full picture. Okay, we can move on to the findings. Okay, so the results are really extremely helpful for prioritizing the needs of health professionals and the general population. For the aging population, there wasn't a lot of services that were directly for these, nor was there much in the way of prevention. In particular, there's a lack of understanding of prevention of NCDs or non-communicable diseases, in particular, obesity and diabetes, hypertension, and heart disease. The development of most NCDs is attributable to lifestyle and diet. So those are things that don't require a physical meeting with a physician, but they are things that should be assessed, and there should be much more developed programs. Additional priorities that we found including assessment and services for individuals with dementia, Alzheimer's disease, depression, harmful alcohol use. All of those posed significant challenges for older adults. The needs assessment outcomes are really going to be the foundation of planning the educational interventions. And these will be developed collaboratively by local health providers with the collaboration and support of our College of Nursing, which does have a geriatric education center that's funded by the Hartford Foundation. Also, we think that there's a role for regional WHO CCs and PAHO to enhance the use of existing resources. It became clear that there were some things available in some islands, but not known to other islands. So more coordination among the islands, I think, is what the take-home message was for us. Can we go to the next slide? So how does this activity support the organization's goals and mandates? This needs assessment supports PAHO and WH goals for the decade of healthy aging. By assessing baseline needs of this Caribbean population that can be used to guide the development of the educational and service programs to enhance the health of an aging population. We found in general that there was a real lack of recognition that people are living a lot longer than they used to. And so the infrastructure for supporting them, it just really was not there. And that's our work for the future, is to build that. I think that might be my last slide. I think it is. Okay.
I think it is. Thank you, Dr. Nancy. It was a pleasure to hear from you on this topic. As you listened in the beginning, I am the advisor for healthy aging. So we are working very hard on this topic, and especially trying to prioritize the issues of the aging population, because as Dr. Nancy mentioned, it is difficult to still recognize that the aging process is so fast and incipient in the region. As integrated care is one of the main areas of action of the decade of healthy aging, which is our main plan of work in PAHO. So such needs assessment is very important. So we can target interventions for older people and explicitly showing their needs, not as an homogeneous group, as it is usually thought about this group. And of course, it can also help to coordinate actions. And as it was highlighted that it was something that it was needed in the Caribbean specifically. And when we revise NCDs for older adults, it's always very important to take a look also in the abilities that older people have, even though they have a chronic conditions, because this is the main thing when we think about healthy aging, is being able to maintain functional ability, which is the ability to do the things that they want at older ages and being independent and having quality of life. So thank you very much for your presentation, and thank you very much, Eliane and Sandy and all the team for having this wonderful webinar put together, and of course the special wish you. Thank you very much. Obrigada.
Obrigada a você, Patrícia. Thank you very much for the moderator and the panelists. So let's move on. I appreciate for the participants who are still here with us. We are doing our best to keep up with the time. So without further ado, we are beginning now panel number 5, which is related to digital health and infodemics. Our moderator, Mr. Marcelo D'Agostino, who is the Senior Advisor on Information and Systems and Health here in PAHO as well. He's on duty travel, and unfortunately, due to a event that is really running late there, he's not going to be able to join us today, and he asked me to take over the moderation. So I'm really glad to invite for his intervention Dr. Francesc Saigui Rubio from the University of Health Sciences from the University of Catalonia, Spain. Dr. Saigui Rubio, thank you very much for being here with us, for your patience, and please, the floor is yours.
Thank you very much. Good morning, ladies and gentlemen. It's a pleasure to be here as a PAHO Collaborating Center in Health. Briefly, after more than 15 years of carrying out activities, carrying out training and research activities in the field of telemedicine and promoting digital health in Latin America, collaborating with PAHO. In 2018, we were designated as a PAHO Collaborating Center in Health to support countries that want to develop new telemedicine services, promote the use of e-health, and study the adoption of the mobile health in countries of the region of the Americas and Europe. So this presentation describes some of the activities carried out as a PAHO Collaborating Center in Health. Our Collaborating Center provides full support to regional initiatives led by PAHO's Department of Evidence and Intelligence for Action in Health, which activities are focused on supporting countries in the region of Americas that want to digitalize their services. At the European level, our Collaborating Center also supports regional initiatives led by the Data and Digital Health Unit of the Division of Country Health Policies and Systems. This unit seeks to develop new approaches and methodologies for the use of new digital technologies in healthcare, such as telemedicine and the use of big data. With the WHO declaring the COVID-19 a global pandemic on 11 of March 2020, a significant number of our activities have focused on providing guidance on how to overcome the pandemic through the appropriate use of information and communication technologies. These actions were led by PAHO and include the preparation of dissemination of technical notes, participation in workshops and webinars, and the development of solutions to address COVID-19. Among these solutions, I would like to highlight 3. The one that measures the level of maturity of health institutions to implement telemedicine services, the one that assesses the capacity of health institutions to collect critical data for decision-making, and the one that aims to assess the suitability of mobile health applications. An essential task of any collaborating center is to generate research-based evidence and disseminate knowledge. To promote the use of e-health to reduce social inequalities in health, a common health model based on the use of digital platforms was developed in collaboration with PAHO. And finally, the possibilities to develop international telemedicine in Latin America were also studied, and some recommendations for strategy and public policies were proposed to promote its adoption. At the European level, we explored the relationship of e-health with robots and artificial intelligence, how digital data supports surveillance strategies in the context of COVID-19, and the requirements for improving routine health information systems for health systems management in the whole European region. I would like to conclude this presentation by stating that social distance with measures imposed as a result of COVID-19 together with the lack of specialists and the size of country are factors that have driven the implementation of a variety of new telemedicine services. However, although health services can be largely provided remotely via telemedicine, this change has not yet fully consolidated. In this context, PAHO and WHO, together with the collaborating centers, as a WHO collaborating center in health, have an important role to play in its final normalization. Finally, all the actions presented here are useful in understanding the challenges of providing all the evidence and support that PAHO and WHO needs to formulate strategies for the widespread adoption of telemedicine in health. Having reached this position, it's important for collaborating centers to help PAHO and WHO in one way or another to influence the decision-making at the policy level, both nationally and internationally. That's all. Thank you very much for your attention.
Thank you very much, Dr. Saidi Rubio. Excellent explanation. Let's move to the next panelists for this panel, and then we wrap up with the final comments of this panel. I'd like to invite to the floor Dr. Ian Brooks, who is the head of the WHO Collaborative Center located in the Center for Health Informatics in the School of Information Sciences, University of Illinois, Urbana-Champaign, USA. Dr. Brooks, the floor is yours. Thank you very much for being here with us.
Thank you, Eliane, and it's good to be here. So I'm going to talk about some work we did over a 6-month period. My slides, with a large consortium of consultants from PAHO, from a number of different organizations, including the Library Reserve Corps. We were set a question in early 2021, how can PAHO help member states respond to the infodemic? That's the flood of information, good and bad, that is accompanying a pandemic or another health event. How can we help people figure out how they should help their population respond? So there are 2 ways that a member state may want to interact with the center with health misinformation. One is if they know that there is a particular piece of misinformation which is causing a problem within their country. In that case, we provide tools to help them figure out what is the truth behind that. The other, which is the main focus of our center, is how do we detect new and emerging threats from the 800+ million tweets and other social media messages posted every single day. How do we figure out what threat is going to have the biggest effect on public health? How do we figure out what is the evidence or what is the truth behind that threat? And most importantly, how do we recommend that a Ministry of Health or health communication team responds to that threat? So we divided into 3 teams: a detection team focused around data science and using artificial intelligence and big data approaches to sift through this huge amount of data, both in English and Spanish. We intend to eventually extend to Portuguese and other languages to find out what are the new threats. Then we work with an AI-driven tool, multi-language, multi-database search engine that will figure out what is the most important 2 or 3 papers or websites that a public health official needs to see to know what is behind that particular piece of story, and how do we recommend that they respond. And we are using a storytelling approach to the response. So this was a challenge that we were given. Could we do this? And could we do this within a week? And could we do this with the minimal amount of human intervention? So we set up this system. We ran it for, we did a trial run for a week. We saw more than 400 new potential threats to public health. For this particular week, we focused on one that was a story that the COVID-19 vaccine contained a molecule called luciferase, which was a satanic marker based on the fact that Lucifer is another name for the devil in the Bible. We decided this was a potentially high-level threat. The story we chose to tell to respond to it and recommend that ministries use was not dismissing the fact that it's used the same name, but to tell you the origin of the name of Lucifer, that it means light-bearing, that it is a kind of molecule that is used and gives off light. So it's in fact part of nature's miracle because it's underlying fireflies and glowworms and bioluminescence. So to turn it around and say, no, it's a scary name, but it's not a scary molecule. So this was a proof of concept project that took 6 months. There were, I think, 14 PI authors on the paper. This was backed by a group of more than 30 students who had kind of playing around with how to detect and how to respond. I think we showed that this was possible to do. We actually have a proposal pending to turn this into a production resource so that on a weekly basis, we can do this detection, evidence, and response cycle and provide to member states recommendations on what is the biggest threat we are seeing now and how should they respond. Thank you.
Thank you very much, Dr. Ian Brooks. Once again, we understand the importance of the two papers for everything that we have discussed. And we heard about knowledge gaps, misinformation, infodemics, fake news in a couple of papers, the systems, digital health, and is one of the priorities for the region to support countries and of course, to build inside PAHO the capacity to work with new technologies for innovation and to fight fake news and misinformation. So there's a lot of potential for the collaborative work among the collaborating centers towards this same goal. So thank you very much once again. And without further ado, finally moving for the very last but not least important panel number 6, which will be addressing the neglected diseases. We like to invite Dr. Ruben Santiago Nichols, who is the advisor on neglected infectious disease in PAHO WHO. Thank you very much, Dr. Nichols. The floor is yours. Thank you again for all panelists to stay here with us so until now.
Thank you very much, Eliane. Let me introduce, without further delay, Dr. Teresa Giorgos, who is a very good collaborator and friend of PAHO and WHO. She is the director of the PAHO WHO Collaborating Center for Research and Training in Parasite Epidemiology and Control, based in the Faculty of Medicine and Health Sciences of McGill University in Canada. So, Teresa, the floor is yours, and thank you very much.
Thank you very much, Santiago. I would like to ask thank you. So I would like to talk to you about the article on eliminating morbidity caused by neglected tropical diseases by 2030. So I'm the director of this PAHO WHO Collaborating Center for Research and Training in Parasite Epidemiology and Control. And my co-authors include my colleagues from PAHO, Dr.
Nichols and Dr. Saboya. And the focal point for one of the neglected tropical diseases at WHO, Antonio Montresor, my colleague from Peru of long-standing, where I've conducted my research program for over 20 years, Dr. Martin Casapia, and the rest of the co-authors are my team in Montreal, Canada. Neglected tropical diseases are a cluster of 20, primarily parasitic, viral, and bacterial diseases that affect about 200 million people in the Americas. So about 1 in 5 people in the Americas actually suffer from neglected tropical diseases. You will recognize, of course, Chagas disease, leishmaniasis, soil-transmitted helminthiasis as some of these neglected tropical diseases. So the article that will be in the special issue will show you some of the activities that this PAHO WHO Collaborating Center has been involved in. And we've aligned our activities, of course, with the Sustainable Development Goals, where neglected tropical diseases are mentioned directly within Sustainable Development Goal 3.3, which is to end the epidemic of neglected tropical diseases. And in that regard, in 2021, the World Health Organization came out with a roadmap for how to achieve eradication, elimination, and control of these 20 neglected tropical diseases. And we have worked with our PAHO colleagues and with WHO colleagues in these 3 examples to achieve this goal. One of them is to finalize the monitoring and evaluation framework for the NTD roadmap, where guidance is provided pan-disease and globally, so that every program, every NTD program can understand what the monitoring and evaluation challenges are. And that was published in May of 2021. Secondly, we participated in developing some of the most recent preventive chemotherapy guidelines for control of Taenia solium taniasis. This is a very important disease, especially in Latin America, and the guidance for this was published in September of 2021. Lastly, we formulated a policy brief for deworming for adolescent girls and women of reproductive age. Up until now, deworming guidance has been mostly targeted to school-age children and preschool-age children. And so more recently, we are focusing on adolescent girls and women of reproductive age because of the importance of these infections, the soil-transmitted helminthiasis, in adolescent girls and women of reproductive age. So this PAHO WHO Collaborating Center, we continue to participate actively in helping WHO and the Department of Neglected Tropical Diseases with our PAHO partners in making sure and in implementing the guidelines provided in the roadmap so that we can achieve the goals by 2030. One of the things we are doing is participating in what's called the GAP, the GAP assessment tool, which provides a more qualitative assessment within the monitoring and evaluation framework for monitoring progress for the NTDs. We also participate as a member of the Canadian Network for Neglected Tropical Diseases. Many countries now have created their own network for neglected tropical diseases, and we have done that in Canada. And of course, there's the NTD network for all the non-governmental organizations and Nutrition International, for example, and then there are other centers of excellence that we participate in as well. So how do we support the organization's goals and mandates? We do this by collaborating in activities in which we have an expertise. So expertise specifically in soil-transmitted helminthiasis and other parasitic diseases where we can contribute. We want to promote equity in all these activities, and more recently with our focus on including adolescent girls and women of reproductive age in deworming activities, for example. So we want to combat all the neglected tropical diseases, all 20 of them, so that we can reduce the morbidity and mortality which are attributable to these diseases. And in so doing, we are then improving the quality of life for vulnerable people suffering from neglected tropical diseases in the Americas. Thank you very much for including this manuscript in the special issue.
Thank you very much, Teresa. I now invite my colleague and friend, Dr. Martha Saboya. Martha works with the PAHO's Regional Neglected Infectious Diseases Program. Martha, please, the floor is yours.
Gracias, Santiago, y buenas tardes para todos los participantes que aún están con nosotros en esta sesión. Yo voy a presentarles las aproximaciones del artículo publicado en el número especial sobre enseñanzas obtenidas en la aplicación de la serovigilancia integrada de las enfermedades transmisibles en la región de las Américas. Esto es una colaboración entre los Centros para la Prevención y el Control de Enfermedades, uno de los centros colaboradores que tenemos allí para una de las enfermedades infecciosas desatendidas que se llama el tracoma. Cómo nos unimos con ellos para expandir esto no a una sola enfermedad, sino a múltiples, y no solo a un país, sino a varios países. En el artículo hacemos una descripción muy detallada de lo que nosotros hemos lanzado en el 2016, que se llama la Iniciativa Multiplex, que es una alianza entre varios países, la Organización Panamericana de la Salud y los CDC, para implementar una herramienta innovadora que complementa los sistemas nacionales de vigilancia epidemiológica de enfermedades, en el cual queremos usar o estamos usando la serología para vigilar en una sola encuesta, en una sola muestra de sangre, con un solo ensayo de laboratorio, múltiples enfermedades que son relevantes para una población específica. Se incluyen enfermedades tropicales desatendidas, enfermedades prevenibles por vacunación o enfermedades transmitidas por vectores, alimentos o agua. La plataforma única que estamos usando es una plataforma de laboratorio multiplexada que se llama el ensayo de perlas múltiples, y dependiendo del equipo que se use se pueden analizar entre 50 hasta 500 analitos diferentes. En el caso de esta iniciativa analizamos anticuerpos IgG para múltiples enfermedades. Eso incrementa la eficiencia del sistema y promueve la integración. Y lo que buscamos son señales serológicas que nos permitan entender un poco mejor en diferentes escenarios cómo se distribuyen las enfermedades, cuál es la carga, cómo se identifican brechas de inmunidad o cómo se hace la vigilancia en los momentos en que un país ha alcanzado la eliminación de alguna de estas enfermedades. En el artículo también se describen los avances en 3 países que están relacionados directamente con la iniciativa: Brasil, México y Paraguay, que han integrado la serovigilancia a través de este ejercicio en sus sistemas de vigilancia funcionales. Es decir, esto no es un piloto, no es un proyecto de investigación, es fortalecer los sistemas de vigilancia nacionales, en donde en este primer ejercicio que iniciamos en 2016 hicimos encuestas de corte transversal para responder preguntas que son críticas y necesarias para programas de salud pública. En estas encuestas se han incluido entre 6 a 10 enfermedades diferentes en una sola encuesta, en la que tomamos una muestra de sangre seca que se analiza por la plataforma del ensayo de perlas múltiples, que fue transferido, la técnica fue transferida de los CDC a los laboratorios nacionales de referencia de los países participantes. Adicionalmente, en ese mismo periodo de tiempo, 2 países adicionales, Guyana y Guatemala, lograron incluir la recolección de muestras de sangre seca en sus encuestas nacionales, que eran para una sola enfermedad, para analizar múltiples enfermedades hacia una vigilancia serológica integrada. Actualmente, varios de los países se encuentran finalizando los análisis de resultados de múltiples enfermedades, listos para publicar sus resultados y, lo más importante, para usarlos para tomar mejores decisiones programáticas en el control y eliminación de enfermedades. ¿Qué enseñanzas hemos tenido en esta iniciativa? Uno, que para fortalecer las capacidades de los países para que usen la vigilancia serológica integrada en sus sistemas funcionales, se necesita, primero que todo, orientaciones y esfuerzos conjuntos, no solamente entre varios países, sino con el apoyo de socios, incluidos los centros colaboradores, como en este caso. Esto requiere tiempo, recursos para catalizar cambios en la forma en que hacemos la vigilancia, y es más que transferir una técnica de laboratorio, es transferir el proceso completo que sea útil para la vigilancia, control y eliminación de las enfermedades. Y esto solo se logra a través del compromiso político, el involucramiento técnico y la planificación innovadora. Este centro colaborador que tenemos en el CDC, de los varios que tenemos, este específicamente está ayudándonos a implementar en la región de las Américas la agenda que aprobaron los Estados miembros para la eliminación de más de 30 enfermedades infecciosas al 2030 a través de hacer enfoques integrados, estructurados en los sistemas nacionales funcionales, y entonces el CDC con este centro colaborador nos está ayudando a que esa cooperación técnica y fortalecimiento de capacidades sea una realidad en las condiciones de los países. Los invitamos a que consulten y lean el artículo. Muchas gracias, Santiago.
Muchísimas gracias, Marta, y también muchísimas gracias a Teresa por estas dos muy excelentes presentaciones. Yo quisiera destacar algunos aspectos relevantes sobre los dos temas o sobre los dos centros colaboradores. En el primer caso, el centro colaborador dirigido por la doctora Teresa Giorgos ha generado evidencia a través de investigaciones evidencia importante que apoya el desarrollo de guías y directrices y políticas por parte de la OPS y de la OMS para el control de las geohelmintiasis, por ejemplo. Y también participa activamente en el monitoreo y evaluación de los indicadores que nos van a permitir evaluar el avance hacia el logro de las metas establecidas tanto en la iniciativa de eliminación de enfermedades de la OPS como en la hoja de ruta de las enfermedades tropicales desatendidas 2021-2030 de la Organización Mundial de la Salud. En el segundo caso, quisiera destacar que hay dos cosas principales. Este proyecto ha demostrado que la serovigilancia es una herramienta muy útil para fortalecer aún más los sistemas de vigilancia en salud pública. Y además de eso, también ha mostrado la importancia de fortalecer las capacidades para vigilancia en salud pública a través de la serovigilancia integrada, como se ha logrado en los países que ustedes los pueden ver en el artículo, que son básicamente Brasil, México y Paraguay. Esto es clave porque una de las misiones fundamentales de nosotros como OPS es apoyar la construcción de capacidad y el fortalecimiento de capacidad en los países para la vigilancia, control y eliminación de las enfermedades infecciosas en general y en particular de las enfermedades infecciosas desatendidas. Muchas gracias.
Muchas gracias, doctor Rubén Santiago Nicós, por esta excelente intervención. Yo creo que además de esto también sirvió para aterrizarnos y empezarnos el cierre de nuestro webinar. Les comento que durante este día de hoy, que como muy bien dicho varias veces, fue un día bastante extensivo, de mucho aprendizaje, de mucha información. Hemos tenido alrededor de 215 participantes, incluyendo los panelistas y moderadores. Estamos muy felices con el resultado de este webinario. Queríamos agradecer nuevamente la presencia, yo veo aquí que está todavía el doctor Sebastián García Saizó, nuestro director. Muchas gracias por estar con nosotros hasta ahora y conocer la riqueza de trabajo que se fue emprendiendo a lo largo del año pasado. Como muy bien dijo Damián, agradecer a los autores, no solamente de los manuscritos, de los artículos que fueron, que se publican al día de hoy, como también todo el esfuerzo de los demás autores, de los demás centros colaboradores que han sometido sus manuscritos, que han buscado participar de este importante momento de la organización en dar voz, en abrir espacios, en abrir canales de comunicación, de integración, de visibilidad y de la certeza que estamos en el camino correcto de trabajar cada vez más con nuestros centros colaboradores, no solo los que están ubicados en la región, como también en otras regiones, en otros continentes. Muchísimas gracias a los que participaron, nuevamente al equipo que organizó este evento, a Sandra Weinger, Jessica Williams, Nan, el equipo de ITS, los intérpretes, Isabela Varenga, ojalá no esté olvidando a nadie, el equipo de la revista, que están aquí también, que yo veo, Olga Zerpa, Liliana Liebstein, Sandra Heiger, que subió todos los manuscritos a un tiempo récord también. Entonces, muchísimas gracias porque nuevamente fue un esfuerzo conjunto entre estos dos proyectos que tanto valoramos en la organización. Esperamos muy pronto empezar a organizar el segundo webinario regional de los centros colaboradores, tener más oportunidades de compartir, de dialogar, de encontrar las respuestas o buscar nuevas inquietudes donde los centros colaboradores sigan apoyándonos y haciendo con que las prioridades, los mandatos de la región y a nivel global también se logren y se alcancen. Muchísimas gracias a todos ustedes y con esto damos por terminado nuestro webinario de lanzamiento del número especial de los centros colaboradores en la revista Panamericana de Salud Pública. Muchísimas gracias, feliz día, feliz viernes, buen fin de semana a todos. Muchísimas gracias.
Muchas gracias.
Chao, chao.
Muchas gracias, muchas gracias.